Welcome to MedMythbusters HIV. I'm Rachel Deere with DKB Med. We're starting off a 4-episode series debunking myths about HIV. In the first episode, we talk about trends in HIV incidence, treatment, and prevention. Now, I'd like to introduce our esteemed faculty, 𝐜𝐫𝐿 Sullivan, a certified physician assistant based in sunny Los Angeles, California. Our learning objective is describe recent trends in HIV incidence. Drum roll, please. 𝐜𝐫𝐿, take it away.
Thank you, Rachel. So the first myth, HIV is no longer a serious public health threat in the United States. This is definitely a myth. So there are approximately 38,500 new HIV diagnoses made in the U.S. every year. And this can be due to significant gaps in testing, linkage to care, and adherence to treatment, particularly among racial and ethnic groups, rural populations, or those who are uninsured. It's really stigma and structural barriers that continue to drive these preventable infections. And I always like to tell people that something that I learned at an HIV conference, which an expert said, we already have all the tools we need to end the HIV epidemic in the United States. So we have all the medications, we have all the science, we have all the knowledge. And really what is continuing to drive these infections is stigma and barriers to care. So I want you to keep that in mind as we move through the rest of this episode. So this is a graph of new HIV diagnoses by year. So we're looking at 2008 to about 2024. And so we can see that there has been a decline in new HIV diagnoses over these past 16 years. However, it's not as significant as maybe we might expect. There's a noticeable drop in 2020, but that was most likely due to interruptions in testing and reporting due to the pandemic. And another thing I like to point out on this slide is that PrEP, which we're going to talk more about, became available in the year 2012. And so between 2012 and 2024, we haven't made as significant of a decline in these new diagnoses as maybe we wanted to or should have. And so keep that in mind as well, especially as we get later into the presentation and start talking about prevention strategies. HIV does not discriminate. It certainly impacts everybody. However, Black and Hispanic individuals are disproportionately affected by HIV, and there are some geographical disparities too, which we're going to take a look at now. This is a map of new HIV diagnoses by state, and as you can see, the Southeast accounts for the largest portion, 51%. So over half of these new diagnoses are occurring in the South. I am from Alabama. I was born there, raised there, did all my training there, and I can definitely attest to the fact that the attitudes surrounding HIV and STIs and sexual health in the Southeast are vastly different from where I am now in California. On both the population patient side, as well as when you're interacting with healthcare providers there. And so if you are listening to this and you're in the Southeast, we need your help, so pay attention. The next one is that HIV primarily affects gay men and or people who inject drugs. This is false. While HIV does disproportionately affect gay and bisexual men and those who inject drugs, again, it does not discriminate. It can affect people of all genders, sexual orientations, and backgrounds. In fact, in 2023, cisgender women accounted for approximately 20% of all new HIV diagnoses in the United States. So that's pretty significant. In terms of new HIV diagnoses by transmission category, in 2024, male-to-male sexual conduct did make up the largest percentage of new diagnoses. However, heterosexual transmission made up the second largest group of new diagnoses by transmission category. And actually, the proportion of HIV transmitted via heterosexual transmission increased from 21% in 2020 to 25% of new diagnoses in 2024. To that note, this graphic highlights an important and sometimes under-recognized issue in HIV diagnoses, which is who we as healthcare providers are perceiving to be at risk strongly influences when testing happens. And so what we can see here is the percentage of patients who were stage 3 AIDS at the time of their diagnoses broken down by transmission category. So, what's notable here is that heterosexual men had the highest rate at over 33%, which is pretty substantially higher than the male to male sexual contact populations and other groups. Heterosexual women were also coming in at over 21%. And so, the key point here is that these patients are not being identified early enough, possibly because of lack of perceived risk on the healthcare provider's side. So we as clinicians may not routinely perceive heterosexual patients as being at risk for HIV, which can lead to less frequent screening, delayed testing, and ultimately a later diagnosis. The next one is that people living with HIV that is virally suppressed do not transmit the virus to sexual partners. This one is a truth. So the science here is definitive. And if you don't take away anything else from these presentations today, this is what I want you to take away. And that is the concept of U equals U. Undetectable equals untransmittable. And what we mean by that is when a person who's living with HIV maintains an undetectable viral load, so they're taking their medications, they're remaining adherent to treatment, and that viral load is undetectable, the risk of transmitting the virus to their partners through sex is virtually zero. This is an evidence-based message, and it is really central to reducing stigma and motivating people to stay adherent to treatment. So, our goals of treatment for patients living with HIV is to achieve and maintain that undetectable status. Again, U equals U. Tell your friends, tell your colleagues, tell your coworkers. This is something that most people should know and understand if we're going to reduce stigma around HIV in the US. Next one. Condoms are the only way to prevent HIV transmission through sex. This is a myth. Condoms are a very effective tool at preventing HIV and other STIs, but they are definitely not the only way to prevent HIV transmission through sex. So we're going to get into PrEP, pre-exposure prophylaxis, which are medications that a patient can take to prevent the transmission of HIV. There are multiple forms available, which we're going to talk about a little bit more, but the point is condoms are not the only way to prevent transmission, although we should be encouraging them as they are effective and can prevent other STIs. So, when should PrEP be considered? Sometimes people may be asking for PrEP without even disclosing their specific risks. And so, you want to think about PrEP when patients are coming in requesting STI testing, if they've had an STI diagnosis in the past 3 to 6 months, if you know that they are non monogamous or have concerns that their partner may be non monogamous, anyone with a history of injection drug use, those who are engaging in sexual activity in exchange for money, etc. And really, the idea here is that people shouldn't necessarily have to ask you specifically for PrEP. We as clinicians should have the responsibility to offer PrEP to really most patients. Lots more people in the United States could benefit from taking PrEP than are on it and who are offered it. So a lot of times patients may not even know that PrEP is a medication that exists or that they may benefit from PrEP. So it's on us to really make it known to our patients that it's available and to actively be offering it and educating patients about it, because maybe they're not ready to start it at that time, but just increasing the general knowledge of PrEP and its availability is a win. So let's talk about what options exist for PrEP. So currently there are oral and injectable options. The first option we'll talk about is TDF, tenofovir disoproxil fumarate, and FTC, so tenofovir and emtricitabine. This became available for PrEP and was approved in 2012, and it's meant to be taken daily. It's a pill. You can also use this form of PrEP in an event-driven way or PrEP on demand. So there are specific instances in which maybe daily medication is not the perfect fit for that patient. So just know you can also take it in an event-driven pattern. There is another pill option, which is also tenofovir. This one is tenofovir alafenamide, or TAF, also combined with emtricitabine. This became available in 2019. So those are the pill options. Again, they've been around, first hitting the market in 2012. And in 2021, the first long-acting injectable form of PrEP hit the market. It was really very exciting because if you work in healthcare, if you're a clinician, you know that adherence to daily medication is a huge challenge no matter what disease state you're treating, whether it's, HIV prevention, hypertension, diabetes, it doesn't matter. That daily pill and adherence to a daily pill can sometimes be extremely challenging for patients. And so in 2021, cabotegravir became available for HIV prevention. Cabotegravir is given as an intramuscular injection, and it's given every 2 months after a loading dose. So the first injection is given 1 month later, the second injection is given, and then all injections after that are going to be 2 months apart or 6 times a year. So it was very exciting when cabotegravir became available for PrEP. It offered the first injectable option for HIV prevention. Then just last year in 2025, we got lenacapavir for PrEP. Lenacapavir is an even longer acting injection. It's an ultra long acting injection. It's given every 6 months, and it consists of 2 subcutaneous injections. Lenacapavir is also associated with an oral lead-in, and so to make it simple, the way it works is the patient comes in, they get their 2 injections. It's the same medication. It's all lenacapavir, but we give it as 2 injections because the volume of the drug is a lot. It's 1.5 milliliters each, and so that's a lot for a subcutaneous injection. So we break it into 2, same drug. On the day of those injections, they're going to take 2 pills, also lenacapavir. The day after those injections, they take 2 more pills, so 4 pills total. And then after that, they're totally done with pills. They never have to repeat the pills going forward. And the idea is that those subcutaneous injections and the 4 pills that they take boost the concentration of the drug in the body. And so it's more readily available. Patients will reach that protective state faster with both the injections and the pills on board. So there's a lot of options for PrEP now. It's really exciting. The contraindications would be a reactive HIV test. Of course, this is only for people who are testing negative for HIV so that they may remain negative. You wouldn't want to start it in those with symptoms of acute HIV. And again, we want this is only for patients with a weight of 35 kilograms or more. Importantly, PrEP can be safely used in pregnancy. It can be safely used in hepatitis B co-infection, and it can also be used for patients who are using injection drugs. We are going to link you to the latest PrEP guidelines, so those will be available for your review. Next one. Once a patient has been exposed to HIV, it is too late to prevent infection. This is a myth. Post-exposure prophylaxis is a strategy that can significantly reduce the risk of HIV infection if it's started promptly after a potential infection. So the idea is that PEP, post-exposure prophylaxis should be started as soon as possible after a potential exposure to HIV, ideally within the first 24 hours, but it can be taken, it's effective up to 72 hours after the exposure. It's taken for 28 days, very safe and well tolerated. It's incredibly important that primary care and urgent care providers and those who are having those first interactions with patients after a potential exposure are aware of PEP because time is of the essence. We can also consider a strategy called PIP, which is PEP in pocket. And in that case, patients who may be at higher risk of HIV or have unplanned exposures will take the medication home with them, keep it in the cabinet, and then they know that within 72 hours after a potential exposure, they need to go ahead and start it. So that's also a great strategy for patients who may be at intermittent or anticipated. So again, really the main thing to know about PEP is that you want to start it as soon as possible after a patient presents to you with concerns for a suspected exposure. And it may not be always obvious. Patients may not come and say, oh, I had a potential HIV exposure 48 hours ago. That's most likely not what's going to happen. So I recommend when patients come in with concern for STI, requesting STI testing, to ask, so when was your last potential exposure? If it was within that 72-hour window, you could potentially start them on PEP. So again, it's on us as clinicians to kind of read between the lines and know when PEP may be appropriate for patients. And again, even if it's not appropriate for a patient in that specific time, making sure that patients know that something like PEP exists. You can simply say, oh, it sounds like maybe this is not appropriate for you at this time, but in the future, please know that there's a medication that can be taken. You can come to me after any potential exposure. We want to start PEP as soon as possible, no later than 72 hours. And what we're going to use for PEP, there are a couple of preferred regimens. One would be bictegravir with TAF and FTC, so bictegravir, tenofovir, emtricitabine. Or we might use dolutegravir with TAF or TDF, the tenofovir options, plus emtricitabine or lamivudine. So there's a couple of different options for PEP. If you're able to, I really like keeping samples of these medications in the clinic. That way, if we have somebody who's going to start PEP, you can literally send them out the door with that medication. It may not always be possible, but if you are in the setting to have it on hand, that's an excellent strategy for patients who may need PEP. Any time the patient leaves is a chance to lose them to follow-up. So we want to start everything as soon as we possibly can. Another thing to think about is any person who is a candidate for PEP is likely a candidate for PrEP. So I would like to talk with them about an immediate transition to PrEP after the 28 days of PEP has finished. So that would be a PEP to PrEP transition. Again, most people who are in need of PEP will also benefit from PrEP, and that is a perfect segue into getting someone who may benefit from PrEP on it. For more information on how to initiate PEP, be sure to refer to the guidelines. Next one. Only infectious disease specialists can manage PrEP, PEP, PIP, and HIV treatment. This is a myth. So the idea that only an infectious disease specialist can manage these things is a little bit outdated, and it really, really limits access to care. I don't know if you have ever tried to refer folks to a specialist, but they tend to be very busy, very difficult to get into. Sometimes there's a waiting, months to get into specialists. And so the reality is that primary care clinicians are fully capable of managing HIV prevention and treatment strategies. And we're really uniquely positioned to do so because people usually feel comfortable with their primary care providers. It's somebody they know well and feel comfortable disclosing information to. And so I always tell my colleagues, if you can manage things like diabetes and hypertension, you can absolutely manage HIV treatment and prevention. And so if you're in primary care listening to this, I would strongly encourage you to add this to your clinical skill set because it can be quite simple and it really is a unique opportunity to end the HIV epidemic in the United States and make a real difference in the lives of your patients. If you need more information on PrEP, PEP, and the things that we discussed in our episode today, all of that information is available on our website. Thank you for watching this episode of MedMythbusters. Be sure to look out for our next episodes where we'll be tackling more myths and truths about HIV.
I think we learned a lot today. Thanks to Asia for debunking those myths and pointing out the truths about HIV. And thank you for watching. Please check out episode 2, where we explore myths about aging with HIV, comorbidities in people living with HIV, and women with HIV. If you'd like to claim credit, please click the Claim Credit button to take the evaluation. Your thoughts and comments are important and help us develop future education for MedMythbusters. For CME information, check out mythhiv.dkbmed.com. Did you know DKB Med provides no-cost continuing medical education for clinicians? Well, we do. And you could create a free account if you don't have an account already at dkbmed.com, and you could start earning your free CME and CE credits. For DKB Med, I'm Rachel Deer. See you next time.